Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The sizing, cementation, and removal of temporary crowns and copper bands is a new duty which is allowed to the registered dental assistant. And this morning I'd like to go over some of these new duties and to give some demonstrations on how these can be applied. To begin with, I'd very briefly like to go over the use of copper bands. This is one banding method that can be used. It has its primary function in banding up teeth for temporary cements. We know that, again, the registered dental assistants are allowed to place temporary cements. Occasionally, teeth will be so broken down that we can't get a temporary cement to stay in, so that the teeth are banded up. On the typodont here, we can take a band of various sizes and find one that fits a tooth, and for our purposes here we're going to use just a first molar, and I'll show you roughly how we can trim this. We take and find a band that'll just slide down over the outside of the tooth, and oftentimes to keep our self in order, we'll take an Explorer or something and just gently put an X on the buccal surface so that we'll know what surface we're on, and then we can take a pair of crown and bridge scissors and trim it to approximately the contour of the gingival tissue. These bands sometimes could be rather firm, and they can be softened by heating them to a cherry red and putting them into water or into an alcohol solution, which will soften them up. Some of them are fairly soft, and we really haven't got to worry about pre-softening them. But these are just simply round tubes of copper in which we have to do a fair amount of contouring and cutting and shaping in order to get them to fit properly on a tooth. But it is one way of holding the cement in for a temporary cement. Very frequently this is used in endodontics. I shouldn't say real frequently nowadays because it's not a common procedure in many of the offices, but it is used to hold a temporary cement in while endodontics is done. After we've cut these surfaces, frequently the surface edge will be a little bit rough and ragged, so we'll want to go back and to smooth the edge out with a 114 contouring plier. This just by pinching and rubbing back and forth on the margins will kind of smooth the margins so that we don't end up with a sharp cut surface. Sometimes our contacts will be a little bit stiff, and when we go to place these on, we'll have to kind of work it through the contact area and slide it on down over a tooth if we have one contact left. But if half or two-thirds of our tooth was missing, we slide a copper band or fit it and contour it to a tooth like that, then we could go ahead and place in our temporary cement, and our temporary cement should hold in place, and oftentimes will hold in place adequately enough so that the dentist can go ahead and do a root canal without everything falling off. And frequently this can be used as an adequate support to apply a rubber dam on or something. So this is basically one method of temporary bands, and they can be cemented with a variety of cements. I'd like to go into our cementation and removal and selection of temporary crowns. And in this presentation, we'll stick mainly with the posterior crowns. We'll go over anterior temporary crowns at a separate tape. But with our crowns, they are made for a variety of purposes, the temporary crowns. And the first purpose is simply aesthetics. This can be either to restore the aesthetics that was originally present if we're in the process of doing crowns or bridges, or it may be to maintain some, restore some aesthetics that has been lost either due to accident or caries or some other problem. But certainly, particularly when you're working on anterior teeth. Patients don't want to go home with a disfiguring look, and so we have to restore it for aesthetics. We also have a major function of either anterior or posteriors of protection. We have a dental pulp which is usually irritated, either from the trauma of just working on it, or simply from the trauma of the caries or from accidental injury or what have you, and we like to protect and soothe the pulp. And of course, any exposed dentin naturally will become sensitive in the mouth when anesthesia wears away to hot and cold and touch and various other things. So our dentin needs to be covered completely. And of course, we have the gingival tissues primarily to be concerned about. The slightest amount of irritation to the gingival tissues can result in tissue management problems and recession of the gingiva and a variety of things. So these soft tissues have to be protected with these interim crowns. I say interim, temporary and interim are frequently used interchangeably with these type of crowns, and you may find either term used. We also would like to restore function, particularly if a person is missing a variety of teeth and is down to the last few teeth, and we start putting crowns on them or something. They'll need something to eat and to chew on during the period in which we're constructing permanent restorations. For the hygienist, there are a variety of places where I think the temporary crowns can be used and useful for a hygienist from a practical standpoint. One is simply temporary crowns which come off before they're supposed to. This is not uncommon. Temporary crowns are meant to stay until the permanent restoration is completed, but they also meant to come off. And so they're not cemented with a real tough cement, and sometimes they'll come off ahead of schedule. And oftentimes this may be when a hygienist is seeing them, or they may mention it when they're seeing the hygienist, or if the hygienist happens to touch the crown a little bit or find it loose, they should be able to re-cement a loosened crown with very little extra effort. These temporary crowns are often needed for emergency situations where a person has got a toothache and we having a difficult time of getting a temporary restorative material in there. Sometimes the patients may have completely lost the crown. They had a temporary crown on there and completely lost it, and we'll have to start with the construction from the beginning. We'll have accidental injuries which may come in and require a temporary crown. And again, hygienists can and will be working in offices without a dentist present. And when these type of emergencies come up, it's anticipated that there'll be somebody there to take care of it. In the past, if the dentist wasn't there, the patient didn't get any treatment at all. And it's not a real difficult area, and so a hygienist should be able to step in and to handle it. The loss of porcelain jacket crowns is something that happens occasionally just due to fracture, and all of a sudden it's gone. And many times, if a hygienist has the time or is available, she's able to put a temporary crown on. You make a friend in a hurry. Hygienists are also given the delegation under the new rules change to be a supervisor. Assistants who have the registered dental assistant certificate will be allowed to do this, but they have to do it under supervision. And this supervision can either be from a dentist or from a dental hygienist who has the registered dental assistant certification. And so even though a hygienist may not do some of these tasks, he may be called upon from a legal standpoint to supervise assistants when a dentist is out of the office. The actual construction of temporaries that will go hand in hand with the routine crown and bridge construction will probably fall more directly to the dental assistant, but it's something that hygienists will need to know how to handle also. Let's look at the different types of posterior crowns that we have. There are a variety of posterior crowns that can be made, and we'll just discuss a very few of them here. The first type is what is called an aluminum shell of totally uncontoured type. And this is simply a tube of aluminum that is capped at the end. They usually have numbers on them, but they are just simply a round tube, and this was the first type that came into existence really for temporary crowns of aluminum type, and they're fairly commonly found in offices yet today, but they are simply totally uncontoured. Next, they came out with kits of partially contoured aluminum crowns, and these have a little bit of anatomy in them, particularly in the occlusal, starting to round some of the occlusal margins on them. And the one thing that they do not have is they do not have any contour in the cervical portion of the tooth. Again, they are basically straight tubes with just a stamped anatomy in the occlusal of a little bit. And they are also primarily of aluminum type, although they are soft and you can bend them and flex them, but it's hard to adapt them to the cervicals because you recognize that the cervical of our teeth have constrictions where they're narrowing at the cervical, simply from an anatomical standpoint. The type that is developed next and is in common use today is the fully contoured metal crown, and this is called an ion crown. It's probably the most common in market and the one we'll be using for our demonstrations. I say fully contoured. It's fully contoured in so much as not only does it have some better occlusal anatomy in it, but it also has some cervical anatomy to it. And the cervical actually has a constriction, very similar to what the statistical averages of the constriction of cervicals on the teeth are concerned. We do have a combination where we can take a ion crown form and place some acrylic in it, and we can use a combination of the metal as well as the acrylic. And this is one that has been filled with acrylic here. This has some advantages for a variety of reasons, and if we get a chance, we'll go over some of the advantages of filling one of these with acrylic. Before it's cemented, you can modify the size and the shape and the contacts and the cervicals, and you frequently get a better trimming of the cervicals and what have you on it. And also another common method that is used, and we'll discuss this again in construction, is all acrylic temporary. And these are probably about equally used, to my knowledge, as the straight metal crowns. But these, and this is one that has been used, been in the mouth for a month or so and still has some remaining cement on it, but this is a common type also. When you're making acrylics, these are usually made from an impression that has been taken, and you can use an impression of rubber base, you can use one of alginate, you can use one from a plastic crown form shell, which can be made from a study model, or you can use one simply of a base plate wax and use this as an impression to make the acrylics from. But as I indicated, we'll go into those in greater detail later. These can be made either directly in the mouth, some of them, or they can be made from study models frequently that have been taken before the case has been developed. I'd like to go into these are a variety of the different kits that can be used. Many kits come for the different types of copper bands and crown forms of the various types, and most offices have a series of kits that they will be using to work out of, different sizes and what have you on it. The kit that we'll be working out of is our ion crown form kit, and we should become a little bit acquainted with it. In here, they've got numbers on it, and I can get it turned up here a little bit. Maybe you can see some of the numbers. We have the left on the left side of our case here, and the right teeth on the right side. These are just molars. There's a separate kit for bicuspids, but we've got the uppers on the two upper areas, and we've got the lowers on the two lower areas, and they each have a number on them, and they each have a size, which is a millimeter measurement of the mesial distal width. And this is helpful in deciding which crown we need to select. So from one of these kits, one of our objectives will be to find the crown that is going to fit our particular tooth the best. You can buy individuals, as you're aware, to replace these in the kits. For our demonstration here, we're going to be using a full molar crown preparation on a second mandibular right molar. And in our kit, we have a sizing mechanism that comes. It's a little plastic mechanism that is wedge-shaped, and frequently you can take this and slide it through the area that you need, and when it starts to get resistance, starts to hang up, you know that this is approximately the size. And then you can read off of the end of it here, the millimeters on it, and it'll tell you approximately where you're at, and these are kind of broken down into rough tenths, so if it slides about halfway through before it develops resistance, and our millimeter measurement is 10 to 11, we'll know we want something about 10 and a half. And so we go back to our kit and find a lower right second molar of approximately 10 and a half, and they've got one here 10.4 millimeters. And so we would take one of these crown forms and check it for fit. If it doesn't fit, we can change and go to another one, but usually they'll come pretty close. These do have identifying numbers on the inside of them, so that if we get one that's the wrong size, we can always put it into the sterilization and sterilize it up and replace it back to our kit and use a different one. As I say, these are running 40 to 50 cents a piece, and so we don't just discard them. They can be reused if they're not destroyed. One of the big advantages of these metal crowns, and these crowns are actually made out of a tin type material, a softer material than the aluminum, but we're careful when working with the patients not to call these tin crowns. There's a little bit of a resentment, I think, against putting tin can crowns in patients' mouths. They are silver in color, and so we simply call them silver crowns, whether they're aluminum or whether they are these tin crowns. But one of the advantages of these tin crowns is they're soft. And when you go to place them on the tooth, you'll find that they run into resistance as you start to place them on. If you can get them down about halfway like this, that's about the right size, because as we start to apply pressure to them, the cervical will flare out and start to adapt to the cervical. That gives us a very nice adaptation on the cervical. I might demonstrate this a little closer by taking a little crown expander that they have in a kit and seeing if we can find a crown that will set on the crown expander here. And possibly if we get a close-up on that, as I push this down in there, you'll see the cervical portion of it tend to start to flare out, and it actually will become broader and adapt right onto it. And this is what happens on our cervical in the mouth, is that we get a little bit of flaring out and a little bit of adaptation actually as it goes down in the mouth. But once we have this roughly adapted into the mouth, we want to check our occlusion, make sure our occlusion is coming down and that it's clear. Very critical part of this, and we'll have to understand a little bit more about occlusion to make temporary crowns. And then we need to mark the cervical that is below our preparation or at our preparation finishing line or below the cervical, whichever occurs. If the finishing line is below the cervical, which it many times is, we'll mark with an explorer, lightly coming around here, the area in which our crown meets the free gingival margin. And the same will occur on the lingual. We'll need to take and adapt our lingual here. I guess I can't get it so you and Mike can both see on it, but let me mark it and then I'll show you the mark on it. Once we have this roughly marked, if you just scratch it with an explorer, you usually can see where the explorer will mark on there. And then we'll take our crown and bridge scissors again and start to trim this so that it meets our specific contour of the tooth. This is probably the greatest area of skill that is required in the placement of these, is to make sure that we have the cervical trimmed so that it's meeting the gingival margin or the preparation of the tooth. Also, you want to remember that interproximally here, our tissue usually fills in quite high, and so even though we may not be able to get into it with an explorer to mark it, we'll have to clear out our interproximal significantly here. At this time, again, before putting back on the tooth, we'll want to take some crown contouring pliers, our 114 pliers, and simply go back and smooth and crimp the margins of these so that we're not going to be cutting or lacerating. Also with this, you can actually take and crimp the crown in by crimping it on down and narrow the cervical back up if we've begun to spread out or you got an area that's a little wide on it. And this can be again replaced on the tooth. and we can check and see how we're coming as far as our cervical is concerned, and get an idea of where our margins are in relation to the free gingiva, and check our occlusion. We want to make sure that we have contact with our adjacent teeth, and oftentimes you'll have to remark this and take it back out and work on it again, and 2 or 3 times before you get your cervical just the way you want it. We can place a X on the buccal surface, particularly if you get crowns like these second molars, which are probably the most difficult to identify mesial from distal. They haven't got, ideal anatomy in them, and when you're working with them in a hurry and you've got them filled with cement and you're handling them, oftentimes you'll have difficulty determining your buccal from lingual and mesial from distal, and a slight X on the edge of it will help that, or right in the middle of the buccal surface usually. One of the things we can also do with our crown on it, oftentimes the occlusal will be quite thin on our preparation, and when we close down it'll hit an occlusion, or we may trim our cervical just a ½ millimeter short or something. This occlusal can be pushed out, and the occlusal can be flattened a little bit simply by placing it on a hard surface and then taking a flat blunt instrument with usually the handle of a blunt instrument, and pressing down on it. And when we press down on these, they're soft enough so that the occlusal will pop out and leave us somewhat of a flattened occlusal. And when we place this back on the tooth, this will frequently result in our margins dropping down another ½ millimeter or so, sometimes a millimeter, depending on the shape of the tooth that you're working on, and cover a margin that we may have trimmed short. This may also require us to bite down into occlusion and have the patient bite firmly and have them really press hard on it, and they'll actually dent the surface of this crown right on down and establish somewhat their own occlusion in it. Now we go to the cementation of this ion crown form. Okay, Steph. We're going to use for our cementation purposes here a caulk material called IRM. This is a reinforced zinc oxide eugenol material of fairly good strength. The IRM stands for intermediary restorative material. It's a temporary that felt it could be used in the mouth up to a year. If you fluff the bottle on it, following the directions, we're going to dispense here for you 3 scoops of powder, and this is what we'll ask you to use in the lab, and you can place a little bit up in the corner of your pad also. And although when we're using it for a temporary restoration, the directions call for a 1-to-1 mixture on this. For our purposes, we're going to be using it as a cement, so we'll be using 5 drops to our 3 scoops of powder, which will give us almost a 2-to-1 ratio. You notice this has a little holder for the dropper, which is very desirable because we don't want any of the eugenol to get into the rubber dropper, or it breaks the rubber dropper down. You notice in the mixing of this, you can add the powder rather rapidly, add about a half at one time and then about the other half at the other time, and right about at this stage you'll notice that the cement is fairly thick. If you continue to strop and whip this for just a matter of 15-20 seconds here, you'll notice that the material will start to thin out. This is characteristic of most temporary cements containing eugenol. They thicken up rather rapidly at first, and then they thin out as you continue to strop them and whip them. But this is a stropping type of an action that spreads it out and actually takes a fairly vigorous whipping type of an action to get it thinned on down. Once you get it to your consistency, it should be about toothpaste consistency here, and you can take this and simply start to apply it into the crown. These crowns can be filled half to 2/3 of the way here, and we'll fill it making sure that all of our cervical margins are covered. This is the key on the mixing of this, is to see that we have our cervical margins all covered. Once we have it mixed, then we can simply take it and place it into our, now it's a good time to look for that X on the buccal surface here, so we make sure we're sliding it on the right direction. And this can be pressed down into place. We don't want to press it all the way. We can take our typodont and close it down and finish pushing it to place with our occlusion to make sure that we're just down, because we want this in just a normal contacting occlusion. At this time also, we could take and burnish the cervical if we had some rough areas to make sure that it was adapted. But for our purposes here, we're just going to allow this to set and harden up. And for purposes of laboratory and for purposes of hardening it up, we'll take it out of our Visidont and simply place it in a rubber bowl with some warm water in it. And within a few minutes, that should set up. Now, this ion method of using these ion crown forms is probably the most common and the method that you will probably be using on examinations and more likely in most of the offices. And so I'm going to take this time to run over a short videotape that summarizes a lot of these principles in excellent fashion, and we'll do that while the cement is setting up here on our temporary that we just made.
Of the enamel have been smoothed, so there is. The next step is temporizing the prepared tooth. An ion tin crown form is placed on the tooth, and with an explorer, the cervical extent of our finishing line, the crown, is scribed. This is done around the entire periphery of the temporary crown. A crown and bridge collar scissors is then used to trim this crown to the scribed line. It is then tried back on the tooth to see if it does fit properly to the cervical limits. At this point, after the cervical has been trimmed, the patient should close, and a check is made to see if there are any occlusal interferences or problems with the tin crown. This helps also to finish the occlusal portion of the tin crown and make it adapt harmoniously with the occlusion of the other teeth. At this point, it is also wise to lift the crown and double-check our cervical finishing line. You may find slight areas of modification that you would like to change on the crown. Here, overextension is marked with an explorer, and this can be further trimmed with the scissors. Next, the crown is burnished with contouring pliers. If the crown is too large, this procedure will then make the cervical portion smaller, and it will fit more snugly on the tooth. If the crown fits exactly, this step is unnecessary. You'll note that the procedure is done in a burnishing, pulling stroke. The crown is then replaced on the prepared tooth and rechecked to see if it fits on the patient. This can be checked with an explorer. The rough areas where the crown has been trimmed need to be smoothed. This is done with a green stone to remove the rough, sharp areas that could injure or irritate the soft tissue. In order to protect the soft tissue and retard the collection of plaque, a sulci or Cratex wheel is used to polish any rough areas. In this plastic model typodont situation, the tooth is lubricated with Vaseline. This is a procedure not ordinarily done in a clinical situation. The temporary crown is cemented with a zinc oxide eugenol temporary cement. Have the patient close on the crown. Then the cervical portion of this temporary crown is burnished slightly. Care must be taken in this plastic model situation where the plastic tooth may be damaged by too much burnishing. Only a slight, moderate burnishing is necessary to adapt this crown. Have the patient close and hold this until the cement has set correctly. The excess cement has been removed. This well-adapted temporary will hold the abutment tooth comfortably and in good stead until the next appointment.
Our cement is started to set here for us, so we can go into its removal. Many times our zinc oxide eugenol cements, when they're setting, will go through a kind of a rubbery type of a stage before they become hard and brittle. And many times this is an ideal stage to remove the cement. A curette is a good instrument to use. You can use explorers or most any instrument that you like to remove the temporary crowns. But during this setting stage, it'll get into a little bit of a rubbery stage, and it'll oftentimes pull out in large pieces, and many times you can pull it out from underneath the gingiva or into the gingival crevice where we're involved in. This is a fairly critical stage because if we leave cement into the gingival crevice or interproximally and what have you, we can get involved in problems as far as our soft tissue is concerned. But we won't take time to remove this in all of its detail here, but we do want to get the bulk of it off and clean the crown up a little bit. You'll find that you'll have to develop a little bit of a different tactile sense in removing cement because your normal habits for removing calculus is kind of an upstroke, a pulling upstroke on it. And if you start pulling up with the removal of cement around a temporary, you'll pop the temporary right off, particularly if the cement isn't real hard like this instance, which is, as I say, ideal to remove. So in the type of movements that you need to make, you have to make them in a lateral method and slide along the cervical of the crown. I expect that everyone who's working with temporary crowns will have to pull one or two of them off before they find out the direction and the amount of force that it's necessary to remove a temporary crown. But an upward direction is one which we have to avoid in this lower situation. Now, the removal of the crown is an area which you're also responsible for. As I've indicated, these we want to stay until the next time, but we also want them to come off. There are many cements that are used underneath here. When I say many, probably 50, 75 different types that could be used underneath a crown like this. This particular cement is a fairly firm cement, the reinforced ZOE, and it's oftentimes will stay on rather firm. And it's a good experience to learn how to remove a firm one because the easy ones just come off that much simpler and there's not much of a problem to them. In removing them, we can use a variety of instruments. The two instruments which you'll have to use probably will be either a anterior sickle type scaler or a jaquette type scaler. And you can use these by getting underneath the margin on them and simply pulling in an occlusal direction. Sometimes this won't work, and I haven't really pulled on this yet, but another very valuable way of getting at it is to use the adjacent marginal ridge as a fulcrum and actually pry using the marginal ridge as a fulcrum. This is a very common way of getting at it, and you actually have to take the tip of the instrument and stick it directly into the soft crown and then start to use the adjacent tooth, marginal ridge as your fulcrum to pry it up. You can get quite a lot of force in this manner in prying it up, but they can be removed with a variety of instruments, but they'll often be snug, and when they do come off, they'll frequently pop as they pop off, and this is still a little bit into the rubbery stage. You can see it kind of bounce back as we're picking it on up here, but we'll want to harden these up, possibly harder than this, get them nice and firm, and then we'll go ahead and pop them off. And you can see our cement hasn't completely set underneath our crown here yet. It's still in the doughy stage. It sets quicker around the outside there. These crowns can be slit while removing them. You can take an Explorer, or I should say a jaquette if you want, and actually punch a hole in it or actually cut the side of the crown right off. It's good to save the temporary if you can, because if for any reason the permanent restoration doesn't fit, then the temporary can be re-cemented, but oftentimes we will destroy the temporary in taking it off. But the softness, again, is a big advantage during its removal here. I'd like to go over with you some of the problems that we can get into with our temporaries, which are kind of critical. It's quite simple just to take an ideal situation and to construct and cement and remove an ideal crown, but we frequently are involved with crowns that may be a little bit variable. They may have had periodontal surgery and the crown length is not exactly right. It may be that the ion crown forms are too short, even at their full length before trimming. They don't cover the cervical. In such cases, that's an ideal time to select a little bit larger ion crown form and wash it with acrylic and let the acrylic run down and complete the area in the cervical. Another problem that we can get at is one in which we've got contacts that we aren't able to establish. And if we were to use a ion crown form and to cut the contact out, you can see we cut the contact out of this crown form and filled it with acrylic. You could even fill it with a difficult or one of the harder cements. And then the acrylic will actually ooze out of the contact and establish contact with the adjacent tooth. And then we can trim it and polish it to that contact. Sometimes, because of various reasons, the cervical width of a tooth and the actual mesial distal width of the contact don't match up exactly perfectly, so we'll have to modify it a little bit. We usually will modify it by fitting the cervical to the tooth and then modifying our contact by trimming a little hole and allowing the acrylic to establish our contact. Occlusion is a very critical thing on these, and we have to be sure that we're not in heavy occlusion. If we are, the tooth is going to become very sensitive, and one of the advantages of these soft materials are that in time, particularly if it's a lateral excursions, they will actually pound a hole right through the crown or smooth it out and wear it down fairly rapidly, but it is uncomfortable, and we oftentimes will want to be checking this out with articulating paper to make sure that the patient is comfortable. Frequently you can hear the good sound that will occur when a person is hitting with all their teeth together in comparison to a rather dull thud when they're touching on a temporary. If you just have them kind of tap together, and you can oftentimes tell by the sound. Very frequently patients can tell you when the occlusion is high. They frequently will feel it even under anesthesia and be able to say that, you know, hey, that's not right, it's bothered me, before they get out of the chair. So these are, you know, ways that we have of detecting the occlusion when it is high. The actual accuracy of trimming the cervical is rather critical and can lead to some problems. If we cut the cervical short, then the patient is going to have a sensitive cervical. This is the most sensitive area of the entire tooth anyways. And when they eat something sweet, drink something cold, try to brush their teeth or what have you, they're going to be uncomfortable. And the fact is, I've experienced patients who have been so uncomfortable wearing the temporary that they refuse to go ahead and have any more crowns made because they just weren't going to go through that type of discomfort again. And if you happen to be the hygienist and all of a sudden placing temporary crowns and all of a sudden the patient has refused treatment for a lot of other dental work because of a ill-fit temporary, it could be embarrassing. You say, well, the easy way to do it, but you leave the margins a little bit long, but again, you get into a similar problem leaving them long. As much as you develop a gingival irritation, the tissues are sore, the tissues are frequently a little bit irritated because of the preparations that are done on these teeth, and if you leave a irritating temporary down there, then they just don't have a chance to heal, and they'll bleed, and the patient tries to eat on them, and they're tender, and they're complaining also. And probably the most important problem with an overextension is simply the fact that we can get a permanent recession of the gingiva, and a margin that the doctor may have had tucked just slightly into the gingival crevice. When he gets ready to put on the permanent crown, you find out that, you know, the gingival crevice is no longer there. It has receded a millimeter or so, and his margin is exposed into the mouth. In a mouth with a high caries index, that could be rather critical. So we need to, put our margins right where they belong, and this is the most important part of establishing this, is to make sure that our margins are where we're at, and our contacts mesially and distally are where they're at, and occlusally we're got a satisfactory contact so the tooth isn't going to drift or tip or extrude, or when the doctor gets his crown back and puts it on, find out that the tooth is extruded a ½ millimeter and the occlusion has to be completely reground and take an extra ½ hour to do that, and or remake the crown. This can be very difficult situations if these temporaries aren't just right. Of course, young people have a much greater tendency for movement in their teeth, and we have to be very critical in a young person in making crowns and temporaries, because their teeth move with very little force on them. If we leave cement in the gingival crevice, this frequently can cause a irritation, redness and swelling and soreness in the gingival crevice, and it frequently can result in a permanent recession of the gingiva, which could be difficult, particularly in the anterior if you're trying to hide an aesthetic cervical margin, and you've got it tucked into the gingiva, and then the patient comes back with a temporary that was slightly ill-fit or a little cement left in the crevice or something, then we have a crevice which has been receded, and we have a cervical margin showing, which can be, difficult. So there's a significant amount of skill that can be developed in these. Now, we should give our patient some instructions after we've placed a crown on here. Naturally, the patient's soft tissue is going to be sore. Frequently, if a crown preparation has been recently done, the tooth will actually be sore and the pulp a little bit irritated. One of the advantages of using a zinc oxide eugenol cement rather than a phosphoric acid-based cement like our zinc phosphate or other cements that may contain water, or the polycarboxylates which have no eugenol in them, is that the eugenol will sedate the pulp and help to quiet it down. But the patient can expect to have a sore tooth, a little soreness to holding their mouth open for a period of time, a little soreness to the temporary crown, and particularly around the gingival tissue, and they might as well be warned about this. But you have to be careful to indicate that the soreness is more of a aggravation, irritation type of a soreness. It's not going to be anything acute or pounding or throbbing. Occasionally you'll tell them it's going to be sore, and the patient will have a pulpal degeneration under a preparation or something that we're trying to save, and go through some real excruciating pain and not bother to call back because you told me it'd be sore. So we have to differentiate a little bit between the type of soreness. It should be an aggravation, irritation type of soreness, nothing severe. If it's severe, they're to recontact the dentist on it. They should be able to eat on this normally and brush it normally. Sometimes we have to be a little bit careful with the use of floss. Occasionally they won't be able to get floss through the contact, and you may have to tell them to stay out of the contacts with floss for a little bit. We can oftentimes determine how their use of floss will be, because in cleaning out the cement, particularly when it gets hard and it gets a little crispy, we'll be taking floss and running it through the contacts to make sure that the cement is out of the contact. But if they take a floss down through the contact, and then when they start pulling the floss out, if they pop it back up through the contact or occlusally through the contact, they may well catch under a margin and actually pull the crown off. We've lost crowns with people getting floss in a tight contact and actually pulling them off. These temporary crowns and the type of cement you're using will take a lot of force in the occlusal direction. They'll take all the force generally you can give them. Laterally, they'll take quite a little force, but when you put them into tension and start to draw them directly straight up, then they're not going to take a great deal of force, and many times they'll pop off very easily, even though the patient has been chewing with them for quite a long time. Once a temporary crown has been removed, again, it would normally be the duty of a hygienist or a registered dental assistant to finish removing the remaining cement that is on a tooth and get the tooth cleaned up and ready for the placement of the permanent restoration. In doing this, you have to use just some practical common sense, because the exposed dentin is going to be sensitive, and you might as well tell the patient that it is going to be sensitive. Frequently, I'll compare it to blister and tell them that their tooth is much like a blister. It has the top peeled off. We've taken the enamel off of the tooth, and the tissue underneath it is just tender. And even though on a blister, all you have to do is just to touch it, and you usually will get some sensation on it. This is all we have to do in a tooth with the enamel off, is just to touch it with an instrument. Particularly a scaler is oftentimes quite sensitive to it. And if you touch it with a piece of cotton, or moist cotton, you can find sensitivity. What we frequently will do will be to rinse off the pieces of cement, but again, you have to be careful to use water that is lukewarm or something. You don't want to take and squirt a sharp blast of cold air or cold water on a sensitive tooth. You have to use a little bit of judgment, and this is a place where you can use a little bit of care. You say, why don't we anesthetize these teeth for this procedure? Occasionally they are. Some dentists routinely do it. Some dentists never do it. Some dentists occasionally do it. I think you'll find that oftentimes the sensitivity is minor and is not really that big of a problem to require anesthesia for the cementation of a crown. Many times you may be working with endodontic teeth which have no pulp in them at all. Then you haven't got this concern. You can wash and flush and blow them out with water and air as hard as you want, really, and just have to be careful with the soft tissue around it. So these are our considerations which we should keep in mind on these. Instruments that you will need to bring to the laboratory. For our exercise today, we'll want you might make a note of these and jot them down, our crown and bridge scissors, 114 contouring pliers, both of which you should have picked up from the instrument room. Just an explorer of some nature to mark the cervicals on these. And if you've got a piece or two of floss you want to bring along to help clean out the cement, that would be helpful. Your ion crowns we need in the laboratory, and we didn't get as many of the crowns as we had anticipated. We anticipated each getting a kit of 4, and I understand they only ordered 1 each. I think we'll be able to get by with the extras we have. We won't be able to run through 3 or 4 crowns each and trying to fit one on. We'll have to be a little bit careful on the number we use. But please bring them to the lab, and if you're not coming to the lab right away, either drop them off or give them to somebody that is coming to the lab. We're not going to keep track of people's names and check you in on every single crown. I can trust that 40, 45 cents isn't going to, 50 cents, whatever it is, break you to get a crown to the lab. But if we don't have enough crowns, we're not going to be able to get through the exercise. And we need an assortment. So everybody has to turn in their crowns to begin with, even if you're going to your rubber dam placement. We need your crowns today. Your number 1 plastic Tarno instrument is frequently helpful for placing the cement into the crown or burnishing around the cervical of it. Your cement spatula, obviously, for mixing your cement, typodont and punch, your rubber bowl for putting some hot water on this, and some scalers. We'll need your curette and a sickle or a jacket or something that you'll be able to clean the cement off with and take your crown back off with. So those items you should bring to the lab. We're going to divide the class in half, and at least the half that's left from the rubber dam exercise. Those of you who are in the rubber dam exercise will be going straight from the lecture room to the clinic and start to apply rubber dams on each other. The remaining 2/3 of the class will come to the laboratory and start our exercise in the laboratory. Again, I don't think that it would be desirable to have the entire class there at 9 o'clock or shortly thereafter, so we'll have to break it down. And we haven't made out a list. Let's just say the last half, roughly, of the alphabet will come first at 9 o'clock, and any other students that have an 11 o'clock class should come at 9 o'clock, so you can be sure to be through and there'll be no hurry on it. And remaining part of the first part of the alphabet come around 10, and we'll try to break it down so we haven't got everybody bunched in one area to apply these crowns. But we will be taking and contouring one of these ion crown forms and sizing it and fitting it. We do have natural teeth for you to put in your typodont. These are full crown preparations that the sophomore students have done for their practical examination in Crown and Bridge last year. They are a permanent record in the files of the school, and we will be dispensing them to you in an envelope which has the student's honor code name on it. It's important that we do not mix these envelopes and teeth up, that the teeth, after you're done, get taken off and placed back in the envelope and handed back into us so that this can go back into the permanent record file of the sophomore students. But these teeth are available for us to work on. Most of them will be, all of them I believe, will be second molars, and they'll be placed in the second molar position. Some of them will be right, some of them will be left, and with a full crown prep on them, you won't be able to tell which is which by looking at them, so you may have to try them and fit them in to see whether they go down and where they go down best in the typodont. We'll furnish you also with the IRM cement and the cement pads, and I think the rest of it, as long as you bring all your proper equipment, should flow fairly easily. Again, we'll be working out of the freshman laboratory on this, and I appreciate your patience with some of our technical problems here this morning. We ran this live simply because of the nature of having to not having enough time to have made a tape for you on this, but I think you've each had a demonstration on it and should have a pretty good idea of what we're going to be expecting of you. We will not be trimming and placing copper bands. I think if you can trim and place a temporary crown, that you'll be able to handle copper bands easily if they come along. So let's try our posterior ion crown placement this morning.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.